I'm a beginner in the ketogenic diet, and it's working very well for me, but for my wife, it has been difficult for her to get into the ketosis. And she also freaks out because as she increases the fat, she started seeing that the scale is getting up. So I'm telling her, like, wait first to be in ketosis, then you eat fat. Maybe the strategy for you could be increase the intervals for eating, but in her mind it's so difficult to get this concept because she's so used to eat many times a day, I don't know, 3 times at least. She's doing her best. Only yesterday that she got 0.9 of ketosis, but most of the time she's below 0.4. So is there any advance for her how maybe the problem with a woman is, as you said, regarding being afraid of fat, maybe the problem is that they start eating the fat and they check the scale right away and then they are gaining weight. Is there any trick that could be helpful for her? I'm trying to stimulate her to go into ketosis.
Thank you very much for your comment. So you're basically saying that you notice that she's losing more weight when she's able to eat more fats, but still, no.
No, what I'm saying is that as she stops carbohydrate and she goes into the eating fat, she checks the scale that says that she's heavier, she's gaining weight. So, and at the same time, as she checks the ketosis is still below the desired levels.
Okay, so you don't see any progress even when reducing carbohydrates and increasing fats. So you wonder what is the key. You also see that her ketones are not going up, right?
Correct.
Yeah. So my advice, and perhaps we can also ask for, I'm not a medical doctor, but what I see is that, yes, there is a variability at the beginning and in response to ketosis, and sometimes being too fixated on the number of ketones in the blood is not a good idea. There are so many factors that can influence that. The most important thing, I think, is make sure that at the beginning you are consistent with decreasing carbohydrates, increasing fats, and then if really that doesn't work for a couple of weeks, then you can start considering shifting things, perhaps foods. For example, genetically, there are people that respond to saturated fats with an increase in cholesterol, and they are high responders. And those people benefit from a ketogenic diet based on more olive oil and fish. So perhaps, after 2 weeks, if that doesn't work, you can consider changing the foods and then see. And anyway, changing routine sometimes helps, because you are more likely to get back on track and pay attention to your macros. So this is the tip that I can give, but probably...
I would absolutely, I don't know if this is on. I would absolutely agree. I would absolutely agree with that. I think, a lot of people are chasing their ketones. So they're pumping a bunch of fat in, you're trying to lose your body fat. So at some point, do you want to burn your own fat or exogenous fat, right? So some people are just eating stuff all day, adding all these calories. They're taking in a ton of calories. When we say calories don't matter, we don't mean, I think it's more having satiety. So if she doesn't have to eat 3 times a day, if she could eat twice a day, great. If she could fast, great. Because I've had patients lose, one of my guys, Italian, lost 2 pounds and reversed his diabetes with 2 pounds of weight loss because he emptied his train. He didn't have fat stored around his liver. So sometimes it's very frustrating because we focus on the weight loss rather than the metabolic health. So if you're looking at the numbers and you drop your insulin in half, guess what? You're emptying your train out, even if, because we fixate on the weight. It doesn't matter. There's healthy people that are morbidly obese, as we've discussed. So they can still be metabolically healthy and not lose a bunch of weight. So the ketone levels, a lot of people, if you're fat adapted, a lot of times their ketones will be low. When I work out really hard, my ketones drop. Is that a bad thing? No, I'm using that as an energy source, right? So some people with their ketones will go up and down and do weird stuff. So it's really how she feels, are her joints getting better and all those kind of things. In time, you have to be patient with the process. Some people lose 90 pounds in a month, and other people it takes forever. And it's just being patient with the process and trusting and understanding the physiology. That's why I don't like to just give a meal plan. I want you to understand what's happening with the body.
I believe most of you know the work of Dr. Ted Naiman. I think his approach is very sound with the protein to energy ratio. So protein gives you more satiety, and when we do low carb, we are already removing part of the energy, but if you go too high on the fat side, then as you said, you are burning the fat you are eating, not your own. So I do think his book is a very good source for solving this kind of problem.
I 100% agree.
Thank you very much.
Thank you.
Yes, I am living in nutritional ketosis myself right now, and I'm trying to get my wife and daughter on board gradually on the low carb train, not necessarily ketosis, but low carb. And our excellent direct primary care provider in Fort Worth, Texas, where I'm from, has suggested that because my wife and daughter are ApoE4 genotype, they're both 3/4s. I'm a 3/3, they're both 3/4s. She has suggested that most of their saturated fat content probably should be more plant rather than animal, avocado, coconut, whatever, rather than the bacon, whatever. Could you comment on that in any of the three of you, the genotype issue?
Well, I think it's very speculative at this point. Yesterday we had a very good talk about this. And it seems that what you need to take care of is insulin resistance. Now, people confound the acute insulin resistance you get when you eat saturated fat with the pathological insulin resistance, which actually gets better as you lose weight and do like a ketogenic diet. So the problem is, as far as I know, we don't have any real science to tell that people with ApoE4 should be eating this or that, so it's all speculation. And my 2 cents are, if you make your insulin levels really low, keep your blood sugars low, you are lowering your chances.
Yes, I can comment something. So we did look at genetics in our primary analysis. We didn't look at ApoE4. We are going to look at many more genes. So perhaps I will have a more precise answer to your question. But meanwhile, I would like to emphasize that ApoE4 is a single nucleotide polymorphism, not a mutation, which means it's common. It's common. And if it's common, it's because it's been selected through evolution. And if it has been selected through evolution, there is a reason for that. For example, we know that the ApoE4 variant is actually the highest frequency in Nigerian Americans who have the lowest frequency of Alzheimer's disease. That means that there is a clear gene-diet interaction. So sometimes the gene is not bad or good per se, but it becomes bad in the context of a specific environment. Now, probably a diet that is high in fat and carbohydrates, like the Western diet, can bring the bad of the ApoE4 variant out into the phenotype, how we behave. But at the same time, we know something from some intervention trials with Alzheimer's disease patients that were treated with MCT oils. So for everybody, as we age, our ability to transport glucose into the brain decreases. Everyone is getting worse, like 20% down. For Alzheimer's disease patients, this is even worse. So one of the hypotheses, in addition to the insulin resistance one, is that Alzheimer's disease patients may actually benefit from ketones because they can bypass this glucose as an alternative fuel for the brain. And in fact, so in these clinical trials, the ApoE4 carriers had a better response in terms of cognitive performance after administration of MCT oils. Now, this is a clinical trial with MCT oils. We don't know how this plays out in the long term in the context of a diet that is truly ketogenic, not high in carbohydrate and fats. So we don't have really the answer to your questions, but we have a proof of principle that, that ApoE4 is not really per se a cause of Alzheimer's disease, and there is clearly an interaction with diet, and probably is not an interaction with the fat, but fat and carbohydrates. And one general, I think I want to make another important remark for everybody. When you read the research papers, please pay attention and the headlines. A high-fat diet causes this and that. Usually, most often, those are called obesogenic high-fat diet. There is really like an acronym for that, OHFD, which is high-fat, high-carb. All my students ask me, okay, I read this study, they say that high-fat diet. I know, I just say, okay, look at the methods. What was this high-fat diet all about? So perhaps, your concerns about ApoE4 and what you read that is bad in the context of a high-fat diet, it's actually in the context of an obesogenic high-fat diet, OHFD. Now you know it. And
so the study where they ingested MCTs and the cognitive deficiency diminished, how long was that? How long did they ingest MCTs?
Unfortunately, that was very short term. So they did the cognitive test, I think, within the same day. There were two studies. But it's not enough. But there is research now. There are clinical trials finally with Alzheimer's disease patients treated with ketogenic diets. So we are experiencing a golden age of ketones. Just stay tuned for the results of those studies.
Thank you very much.
And again, on that, I would just agree. When people say is LDL bad or good, Brett sure will talk about it. It depends what neighborhood it's in. Right, if you have a little kid and Ben Bickman's raising that kid, or they're in their inner city where everyone's shooting each other and selling drugs and prostituting, the odds are that one kid's going to end up bad, the other one's going to end up good. It's not a 100% rule, but what neighborhood is your LDL in? The point is, every diabetic needs to be on a statin drug. Why? Because they're at major risk of cardiovascular disease, and that's the only thing we think helps it. So the argument becomes, why don't I just reverse the disease process and not worry about the statin drug at some point, right? I mean, that's the paradigm that has to shift, because everyone is scared. Every doctor is scared of not putting someone on a statin drug because that's the standard of care.
Here we go again, Dr. Aronica. I'm just an engineer, and I'm certainly not Ivor Cummins. So I don't understand everything there is to know about hormones. And we all know, I think everybody in this room knows that women's hormones are wildly more complex than men's hormones. In terms of confounders in compliance to the keto diet, Could there be an element, I've kind of had this hypothesis in my head, that women's hormones are a lot more complicated and that women's hormones have a lot to do with the success of the keto diet. And we've known about the eating salads diet for an awful long time, and keto's new. So could there be a lot more confounders for women in compliance with that diet?
This is a very great question, and that's perhaps why we didn't look at hormones in our second analysis. It was too complicated to look at too many things. But yes, hormones are actually part of the sex, so is genetics, physiology, so hormones, and anatomy. And these differences are biological differences between men and women that do affect the way men and women respond to a drug or diet interventions. So again, we didn't look at hormones, but so from what I've read in the literature, I see that a low carb ketogenic diet tends to just bring back to homeostasis and regulate the levels of many hormones. And for example, even leptin is a satiating hormone, but and it goes down on a ketogenic diet. You could say, okay, this is a bad thing, but science shows that our body becomes more sensitive to leptin. So it seems that this is only one example. The same happens with thyroid hormones, for example, and with inflammation, with many other processes. So I don't think that probably hormones might be at the beginning a challenge for women, together with their food preferences. I think they are a big barrier. What I talk about today, these are very big, huge players. And then, but down the road, actually women are the ones that can perhaps benefit more from a low-carb ketogenic diet, because they are going to regulate those key hormones that are really key for losing weight, and sometimes they are more out of balance in women than men.
Yes, I was wondering if even with lower compliance, that could explain why they're doing so well, because keto is actually balancing their hormones better, and there's not so much to balance with men.
Yeah.
Thank you.
Just to add to that, Jason Fung and Nadia Pataguana just came out with a book about PCOS, right? They say their biggest side effect is pregnancy. So it's doing something with the hormone, and they're right. I mean, we're seeing that. So there's a lot of people going through dangerous procedures, those kind of things. I would highly recommend that book for anyone. The physiology's there. So I'm paid to observe things. My wife, historically, whenever her period was coming, she'd be craving weird foods that she never ate before. But there's a survival benefit because you know the baby's coming, right, when you're fertile. So there's a benefit to eating more at that time. It's not just to make you fat, right? So hormones play a huge role, and I've seen guys, normalize their hormones, testosterone especially, on a ketogenic diet, especially if they introduce exercise. Yeah, so the hormones play a huge role.
This is a question about ketones and measuring ketones and when to measure them. I've been very low carb for a number of years, so that I know that my fasting insulin is quite low. And just recently I bought a ketone meter just for breath, and I'm finding out that I know that my morning blood sugars are usually in the range of 105 to 110, something like that, and I'm not worried about it, but I never have ketones in the morning. And my question is that because my sugar is high that my ketones don't come up? Is there a good time, better time of the day to measure and see what happens?
Well, I think it just depends on what your goals are and where you're at metabolically, right? Because if you're healthy, you're at a normal weight, metabolically healthy, what do you care about the ketones at some point? Because if you're efficient, someone who's super efficient, people who are doing low carb keto for a long time, my ketones have actually gone down over time. Because if you're not eating as much fat, if you go and eat butter the night before, your ketones will go through the roof, and you go, oh great, my ketones are high. What does that mean? It just means you have high ketones. It doesn't mean anything, right? So having a high sugar in the morning, the first call I made when I started doing low carb, I called Jason Flung. I go, Jason, this is crazy. My sugars are higher than they've ever been, and I've been strict keto and fasting. But when you understand the physiology, like the train, I was letting people off the train. Is that a bad thing? No, that's a great thing, right? When you start understanding, our body is very smart, right? When like if I fast all day, my sugars go up at the end of the day. If I work out hard doing interval training, sugars go to 143 fasted. Well, I'm diabetic by definition. Is that bad? No, it's physiologic. You're emptying the train so you don't get low sugars, right? So our body's really smart. So if you're running low sugars, it's possible you're getting low those sugars in the middle of the night, and then all of a sudden you're getting that dawn effect. Or it could be that your body, it sounds crazy, but Rob Zivas said the same thing, and we've all observed that with a continuous glucose monitor, and other people here may have seen that, is if you're gonna go running that day, your body will spike the sugars before you run. You haven't done anything yet, you're putting your shoes on to go and you spike your sugars because your body says, uh-oh, they're preparing to run. Our body's pretty darn smart. The more you look at these things, you realize, oh, that makes sense. You get super stressed, your sugars go up. Stress hormones do that. So I think the more we're around and more we have data and information, we start realizing we can predict what's gonna happen. It's not that tricky sometimes.
Yes, and actually for many years I was thinking about getting a keto meter or not, and then I obviously said I don't really need that because I am metabolically fine and I don't need to check them. But I decided that maybe I want to see exactly where I am in the ketogenic spectrum and just get the most benefit that I can get out of it since I'm here anyway, and that was the reason that I got the keto meter. And so, the question that is tied to that one is the fat intake. So you were talking before about whether you're burning the fat that you're eating or the fat you have. And so how do I know that, and I know you talk about satiety, but is there a way to know that this is too much fat or too little fat, or I don't know?
Your numbers will tell you. Your numbers and your scale, they'll tell you. You'll see if you're a fit person, obviously. So you shouldn't expect your ketones to be through you don't get an award for having the highest ketones, right? We don't get an award for that. So you start realizing if I'm at 0.2, 0.4, I'm like, okay, I'm in ketosis, that's cool. Like if you're 1.8, it doesn't mean you're burning way more fat than everyone else. Mm-hmm. So people, we start using that as our barometer. It's not a very good barometer. You have to look at the whole picture like we're talking about with the train stuff. It's the whole picture you're looking at. Because is LDL bad? Yeah, it is. If your insulin's through the roof and your sugar's high, it's terrible.
Yeah.
Right?
Okay. Thank you so much.
Hello, I'm Richard Morris. I'd like to thank all of you. Let me try this. Molto grazie. Thank you and gracias for your presentations. I'm trying to get you used to my Australian accent because I'm going to ask some questions. So, Brian, firstly, I want a shout out to Brian, another podcaster. Congratulations, dude.
Hey Richard, everyone, if you hated my presentation, he's the guy who gave me the start. The two keto dudes, they had no idea who I was, and this is kind of funny. I reached out to him and said, I'm giving this free talk, and Richard sends me an email back and says, are you selling ketones? I'm like, no, I'm not selling ketones. Okay, why don't you come on the show? I'm like, you don't even know who I am. But obviously, I don't know if you vetted me or not, but that was very kind, and that's why I did the podcast, because you gave me a platform. I said, well, if I get a platform, I can give it to other people, right?
You're welcome.
But thank you very much. Deeply appreciate it.
Shout out. So I have a statement about uric acid for Dr. Souto, and I have a question about experimental design for Professor Aronica. So the statement about uric acid is that one of the reasons that anything that will crystallize in our joints, oxalates, uric acid, a lot of things will cause gout, but uric acid is particularly bad because it's the ultimate breakdown product of purines, which are in half of our DNA. Adenosine and guanosine are both purines. And one of the funny weird things about diet is that we're told to stay off meat because meat has purines in it. But for some reason, the plant-based people don't realize that plants have DNA as well as animals. So there's just as much nucleic acid that can cause this problem in plants as well. But I don't think that's the problem. I don't believe that eating these foods is the problem. We, as you pointed out, we make the purines because they're in every single one of our cells, and the ultimate breakdown product of that is uric acid. But one of the things that happens in metabolic syndrome is that our ATP goes low and our ADP goes high. That's indicating that we have an energy problem. metabolic problem with their energy. And so when that happens and the body the cell cannot produce more energy, it converts two ADPs into another ATP and an AMP. So this is a state that happens when you're running out of energy, and that AMP goes straight to xanthane xanthanase oxidase and straight to uric acid. So that's why metabolic syndrome people have this problem, because we've decoupled our ability to turn fuel into energy. We start turning it into these metabolic byproducts. And I was a gout sufferer when I was type 2 diabetic, and so I very much appreciated your talk.
Thank you.
The question about experimental design is, Dr. Aronica, how are you able to handle the confound between the men who were on a low-carb diet and had apparent success at weight loss and their greater compliance? Their greater compliance. So the men on a low-carb diet had apparent better success, yeah, and they also had better compliance. So how do you factor for the confound between, hey, I'm doing well, I'm going to keep doing this really hard, and the women who, it's not working for me, I'm not going to, this doesn't work, I'm not going to work that hard at it. Were you able to cater for that confound?
Yeah, if I understood correctly, actually those were two different experimental questions. So our primary question was, is there a difference in weight loss and fat loss when we look at men and women separately? So it's independent, and it's the round one, the sex round. And then we looked at diet adherence. So the first question is a more clean question. You just measure differences in weight loss and body weights, and we adjusted for differences for baseline differences in body weight between men and women. The second question is a more dirty one, experimentally very difficult to tackle. I didn't want to go into the details, but how you compare diet compliance between men and women that are different, so have different body weights, and across two different diets that have a different spread of deviation from the target. I tell you, on the low-carb diet, people deviated much more from the target than in the low-fat diet. So in terms of grams, the deviation was much higher in the low-carb group. So we developed this clever deviation score that is giving us so many problems with the reviewers of the paper who don't really have difficulties with the statistical analysis. Anyway, we are accounting for baseline differences in body weight between men and women in order to compare men and women, and we are standardizing based on the deviation, spread of the deviation in the two different diet groups in order to compare between different diet groups. So coming back to your questions, these are different questions that we wanted to make them separate, because in terms of scientific rigor, when the reviewers read the paper, the first question, weight loss, nobody has problem with that. And the gender one is a much more delicate. We make a point, our way, there's no best way to measure diet adherence. We did our best. Also, these were self-reported data, so people told us where they were eating. We know that this is not the best, but we did have the best system in place to track those data. So we did the best that we could, but this is a more tricky question with many limitations.
Right, thank you very much.
Yeah, and the simple answer too is there's studies, one in particular that I read with men and women on a diet plan, and men tend to go out with their guys and party one night, and then they say, had a good time, starting again tomorrow, get back on track a lot quicker. Women tend to go longer off track, and Siobhan Huggins, she did an experiment with a high-carb, low-fat diet and went to major depression, which was her long history, and she was doing great on her high-fat diet. But then it was hard to come back and get back on track again. So it tells you, when you take vacation and say, I'm going to do whatever I want, those kind of people really struggle if you have a food addiction or if you have anxiety, depression, because that anxiety, depression comes back. Now you got the stress hormone stuff to deal with. And I've always felt this ketogenic diet, low-carb diet works a lot because of the mental, like if you're a stress eater and we calm your nerves, then you don't need to stress eat anymore. So I think a lot of times people will just snap back into what they were doing before they got them into the position where they're trying to lose weight, right? So I think that's a big part of it that we don't talk about enough. The great analogy I heard a guy said, if you're out somewhere and you drop your cell phone and you pick it up and it looks fine, you don't start smashing on the ground and breaking it up, right? You just look at it and say, oh, no damage. So sometimes someone goes for a breakfast and has a donut or something, and they say, well, I blew it, so I'm just going to keep blowing it. Instead of getting back, say, okay, I blew it that one time, it didn't do much damage, let me get back on track, right? So I think there's a lot of mental part of that with the addiction and all that we don't appreciate enough.
Thank you very much.
I just want to comment on the uric acid thing. I have a short story about a patient that illustrates it a lot. So I had this patient that I would see him for his prostate for many years, and each time he came weighing more, okay, and then he became diabetic. And I was always trying to convince him to go in a low-carb diet. And finally he did. And when he did, he went very well. He lost a lot of weight. He reversed his diabetes. And then he told me, he said, Doc, I was not fat when I was young, but I had a gout attack. And I went to my doctor, and he told me I should stop eating meat, fish, seafood, and I should eat pasta, rice. Because you're right. I mean, food also has purines, but if you strip it of everything like flour and sugar, those don't have purines, okay? So that was the thinking. And then he became fat, and then he became diabetic, and then his gout became much worse, okay? And then after a low-carb diet, when he reversed the metabolic syndrome, he stopped having gout. So this is a very interesting case.
Your comment about the biphasic nature, in the early stages, acetoacetate and uric acid compete for disposal. And so in the early days when we first go keto, we have high acetoacetate, and then eventually our redox state gets to the point where we're able to convert everything to like shelf-stable beta-hydroxybutyrate. Acetoacetate goes down, and now uric acid gets out. Yeah,
you're right. There is a competition in the renal tubules, and also insulin seems to augment the reabsorption of uric acid. Yeah. So as you lower insulin, it goes down.
Thank you very much.
Absolutely. Yeah, that's great.
I have a few questions on insulin, checking insulin levels. First of all, do you do that fasting or random? Secondly, how often do you check serial levels? And are you checking these on people who are already on insulin?
Well, you can't really check it on people on insulin. I think the big, because it will confound everything. They shot a bunch of insulin, you're going to see it. So we check a C-peptide if we're not sure. So I've had patients that were diagnosed with type 1 diabetics as a type 1. As a matter of fact, one of my patients who ended, again, it's been, this patient, I warned her for a year she was going to end up with diabetes. While I was in Boca, she ends up in the ICU with diabetic ketoacidosis, right? Because her train full, she got messed up with all this stuff. So we have the warning coming. So checking an insulin will tell us where they're at. Is it perfect? No, but it tells us if it's high, I know there's a problem. So I don't do serial insulin. What I do, personally what I do now, and I'll probably use it a lot more in direct primary care, is saying let's follow your insulin, because if someone loses 4 pounds, they're upset. If I go, your insulin dropped from 40 to 9, that's a marker. That's a marker we can look at and say, because you get stressed, your insulin goes. There's so many factors involved. But at least if you can follow a trend and see you're getting better, I think it helps with compliance. And I think there's a value to, if someone's metabolically healthy, I don't check everyone's insulin level all the time. But if your triglycerides are going up, your HDL's dropping, like that train picture, then I know we better look at and see where it will tell me how full your train is, right? To some degree, how much fatty liver you have. And if we kind of, can extrapolate from that. So what we do is a fasting insulin, because if you're not fasting, I don't know if you're just spiking it because you just ate cookies for breakfast, right? So you want to have a fasting level. And then again, the C-peptide is helpful because if you're making insulin, now you're not type 1, and we're going to manage you differently than a type 1. Yeah, I mean, really, we're trying to cut the carbs. I mean, really, the treatment's the same. Just depends if you're shooting the insulin or whether your body's making it at some point, right?
And are you checking it like every 3 months, or with A1C checks? Or are you checking it 6 months, 12 months?
Well, for me personally, it just depends on the clinical center. I don't have a set protocol that I do. I kind of look at the patient, because I'll tell you what, it's a lie detector test. Because if you say you're cutting your carbs, your insulin's going up, something's wrong, right? Either you're lying or you're getting carbs you don't know about, because it's not going to just shoot up. So when I see someone, that's why Tro, my compadre, right, my mentor now, who I had to mentor at the beginning, now he's mentoring me, is 24-hour glucose monitor. You have a scale, right? Blood pressure cuff. It's a lie detector test. To me, I could tell what's going on. I mean, you're gaining weight, your sugar's going, because we understand from Dr. Unwin's data, from Ben Bickman's data, if your insulin's going up, your blood pressure is probably going to be going up too. Your carbs, all these things are related. They're not individual things. This is metabolic disease. And that's why we're so focused on weight loss instead of saying weight loss is a side effect of being metabolically healthier, right? So it depends on the person and what their situation is. So someone's weight's coming down, their A1C is coming, everything's going great. I'm not going to check insulin all the time. It's a cheap test to do. And it's lack of knowledge. The only thing I can understand, or doctors don't know what to do with it, and they don't want to have to pay because it's a weird test they've never heard of. But I'm telling you, looking at Ben's data, you realize that is going up. It's a warning sign. We're following the A1C. It's a joke. That is an absolute joke. It's malpractice, in my opinion, to follow the A1C before you diagnose diabetes. Why? Because you can maintain that sugar low, but your insulin's going higher and higher. Your train's filling up, and you're waiting till you get that diagnosis. Now you're going to try to reverse that? You got to follow it beforehand. You got to see it on the way up and say, your insulin goes up every time I see you, you're in trouble. So I use it for more of a tool to help people learn how important it is. That's why I think that analogy is so important. And when Jason Fung told me, Brian, that insulin's going to be super high in a newly diagnosed diabetes, didn't make any sense. But when you understand insulin resistance, it makes sense in that setting.
Thank you.
Hi there. I've got a question about, sorry.
You can just tilt it up.
So blood pressure, salt, and a ketogenic diet. One thing that I've seen, it might be a misconception, is that a person might be recommended to follow a ketogenic diet because they've got high blood pressure, metabolic syndrome, etc. But when they hear that on a ketogenic diet that they would probably be eating more salt, that raises a big flag for them. So how do you go about addressing that particular concern? And then I have a second question, and that is, can eating, say, really starchy foods, say rice, potatoes, does that affect blood sugar in any sort, blood pressure in any sort of short-term way, or is that all just long-term? You know, that the person gets unhealthy over time, the blood pressure rises. Is there a really short-term sort of effect that you could just point out to a person, like tell them to measure their blood blood pressure, eat something and measure it after, just to sort of prove to them that, hey, this is happening. Thank you.
Well, if you look at the 5 criteria of metabolic syndrome, high blood pressure is one of them. And probably at least 50% of what we call essential hypertension is actually hypertension that is linked to the metabolic syndrome. So when you look at the data, when you look at the RCTs, the group that does low carb usually drop their blood pressure as they lose weight and they become less insulin resistant. Looks like the problem is not how much salt you eat, but how much salt you retain in your body. And insulin, high insulin, reabsorbs salt in the kidney. Now, the reason you need to eat more salt when you are on a ketogenic diet is exactly because you are excreting too much, which should be good for someone that has high blood pressure, right? So what I think is people advise the population to eat a lot of carbs, and now they must fix it by asking people to eat less salt because they are retaining a lot of salt because they're eating wrongly. Okay, that's how I see it. Some patients that are already hypertensive, and there is a portion of them that are called salt sensitive. So for some people, yeah, you need to advise them not to eat too much salt. But when you look, for example, at the PURE study, those that eat very low salt died more. Those that eat a lot of salt also. But what was the minimum was usually what people will eat if they put salt with the salt shaker to taste, which makes sense because it's evolutionary.
Yeah, I 100% agree. That's absolutely correct. We know insulin makes us hold on to sodium at the kidney level, right? So Christian Assad, a friend of mine now, a lot of you may know him from the podcast, a brilliant guy, cardiologist, expert in heart failure. What does he do? Gets these diabetics who are on tons of insulin, and he says, on hospice, they send it to him because the guy's on hospice, can't breathe, he's miserable. And the guy, he looks at him and basically says, you're on 6 diuretics, you're on all these meds, I can't really help you, right? And the guy says, is there anything I can do? He said, well, you kind of didn't hear it from me, but a ketogenic diet may help you. Why? There's studies that the ketones can help the contractility of the heart. There's studies showing that if you drop the insulin level and get them off insulin, that their swelling in their feet goes away, the heart failure stuff goes away. So guess what? The guy's out hiking now, from hospice to hiking, because Christian Assad said, I'm going to stand and say this is not right what we're doing, because I'm giving you a ton of insulin, and then I'm giving you diuretics to get rid of the salt that you're retaining from the, you get into this horrible thing, it doesn't work. So at some point we have to step back and say, because I personally seen it in my patients, pedal edema, swelling in the feet going away, like that, on a ketogenic diet or fasting. Why? They're dropping their insulin level that's making them hold on to the salt. If 88% of us are metabolically sick, the people who are saying to salt restrict, 88% of the time are right, because you have metabolically sick people. If you make them not metabolically sick, then you lose the benefit of cutting the salt out.
And then to address the second question, say you had a person that was evidence resistant, so to speak, and they demanded a way to really prove that hey,
well, the thing
works.
is, on your question is this. All the time, everyone will know it here, any doc who's a primary doc, I get a call from the dentist, I can't work on this person, their blood pressure's through the roof. 190, 200 over 110. They come to my office, I check it, it's 120 over 60. Why? They were super stressed. They were there. I get stressed when I see the bill from the dentist, but they were stressed because the drills are going and they're stressed. And so white coat hypertension, what do you think it is? Stress hormone spiking, right? So I don't know, I've never said, okay, let's give you salt and check your blood pressure right away. Let's give you sugar and check your blood pressure. But we know chronically, with those 2 studies I presented, Dr. Bickman and Dr. Unwin, they both showed significant benefits while tapering medications. So do I just keep throwing medications on people because it's quicker and easier for me to see more patients that day, or do I say let's attack the root cause?
All right, thank you.
I have a gallbladder question. If you're beginning keto and or you don't have a gallbladder, or you're at high risk for a gallbladder attack, how do you go into the ketogenic diet safely, or is there a risk?
One of the myths that I had was exactly this, but I took it out because of the time. So there is a meta-analysis of randomized control trials about exactly this subject. And what's being shown is that patients that lost a lot of weight with a high carb diet, 40% of them developed stones. Those that lost weight with a low carb diet, 0% developed stones. So why is that? Well, what's the gallbladder for? It's to have the bile concentrated, so when you eat, it will squirt that bile and help you digest the fat. Now, if you don't eat fat, you don't use it. So the stasis, which means the fact that the bile stays there and gets ever more concentrated, then it forms, it crystallizes, forms stones. So if you don't have gallbladder stones, the best way of avoiding them is exactly doing a high-fat diet. Now, what if you have gallbladder stones? Then, well, you may be at more risk of having a gallbladder colic, pain, when the gallbladder contracts. So for those people that are asymptomatic, maybe there's no problem. But if you have gallstones and you have pain sometimes. Maybe you should take it off. What do you think?
I think I want to be your agent. You should speak everywhere. Doug Reynolds, are you writing this down? Man, that's great. Awesome. Yeah, when you're losing weight, the thing people don't realize, and I always warn people ahead of time, on a ketogenic diet, whatever diet, I don't care what you do, starvation, your liver function tests are going to go up, and LDL generally is going to pop up initially, at least initially. You have to be prepared for that. That's why people freak out on this diet. They go, oh my gosh, your liver tests are going. Yeah, because you're emptying the train, all that damage. And I would love to talk to Richard later about how much of that metabolic disease is causing the gout problems. And we already know fructose is damaging to the liver. So is it tissue breaking down that's contributing? I don't know. I'm not a scientist. These smart guys can figure that out. But there's a lot of these numbers we see, and we get freaked out right away by the numbers. That's why it's important to have a lot of data points to understand, and you can see the trends are happening. And as more of us are doing this kind of medicine, we're going to figure out what a normal reaction is. And it's not going to be, obviously, we know what the food pyramid's a joke because all of us have different metabolic needs. What Sean Baker, like his training is so huge, he could eat way more carbs than he does. If he wanted to eat Twinkies, I mean, he wouldn't get diabetes, right? So I'm saying there's a lot, and plus this guy eats 0 carbs and his sugar's high. Why? He exercises at a super high level. So his sugars run high because of that. I mean, it makes sense physiologically. When I first saw it, that was the craziest thing I ever saw. He's eating sugar and he has high sugars, right? So a lot of these ultramarathon guys may be being misdiagnosed to some degree because their A1C is going to be a little high. LDL is almost always high because it's an energy model. If they're burning all the sugar, then they're shifting fat stores out, and we're seeing it in the bloodstream and say, oh my gosh, you're killing yourself, right?
I grew up with an obese family and history of diabetes, so my mother died of it. And then 14 years after she passed, I had, actually 10 years later, I stopped going to the doctor because I was afraid of when I would be told, here's your death sentence. So when I got my death sentence, that was a very depressing day, because that day I knew I was on my way to death. That is not a story that's unique to me. I think broadly we accept that diabetes is irreversible, chronic, progressive, deadly. What do you think, what do you see on the horizon? I know you're starting a new practice, Dr. Lenzkes, and what do you see on the horizon that might, when someone is diagnosed finally by the Western system, diagnosed a diabetic 20 years too late, how can we get the word out? Hey, you know what? You don't have to die of this. What do you see on the horizon, and how best can we help getting that fixed? Because that was not a good day for me. I remember that day.
So, I think the biggest thing is what Dr. Unwin says. Our job is to give hope. If I say you have a disease I can't cure, like this panic is happening because if we had a cure, everyone would say, okay, no big deal. Everyone come into the conference. It's no big deal anymore. So when you don't have a cure, and I tell you I don't have a cure, why do I need to, at the beginning of this thing, you say, okay, I diagnose you something I can't treat. What good is that, right? I got to treat it, right? The disease process. That's the argument for, with prostate cancer screening, if you're 85 years old and you have multiple morbidity and mortality, there's no benefit of treatment. And that's what the data clearly shows. If you're not going to live more than a couple of years, why are you treating something that's going to kill you in 10? Are you going to die in 2 anyways? So I think it's really going to come down to a team approach. What I've learned on the podcast is it's not you say, okay, just cut out sugar and everything's okay. Why did you get to the point you were at? Until we figure that out and go back to the root cause, or you abused as a kid, that may be contributing. Was it that you just love cookies and habits? There's so many different things. It was a simple answer, we'd all be doing it. But I think what we do is when you learn, is there an addiction aspect? Yes, let's get the addiction experts to help with that. You're not going to cure an alcoholic, say, okay, you have to have more willpower, but I'm going to let you sit in the bar all day, right? It's the same thing. We're hammered with food everywhere. Like you watch TV for a couple minutes and what's happening, all these people are sitting at their house, they're stressed out, they're watching TV and they're seeing all this stuff and they go, I need a cookie to calm my nerves. Like Dr. Unwin always said he needed a biscuit, right? This is a 3-biscuit patient. Like he'd get stressed out because there's a rude patient coming in, he would eat something to calm his nerves. So we all kind of do that. So what I'm saying is it's a huge picture, but I think the first thing is to say, we got this. Right? Like when I started leaving, when people say, I got this part of your business, I'll help you with this. When you have someone who says, I got you, and we've done this before, we're not inventing the wheel for the first time. Like when your doctor said, hey, it's been 9 years and that's it, That's atrocious. Instead of saying, let's try something else, right? In the movie last night, all those people, no one ever said, maybe we change what we're doing diet-wise and see what happens, right? Like Caesar salad. How massive is that? Getting your brain cut in, possibly dying on the table instead of changing your diet? It's unimaginable to me that we don't look at these things. But I think the big thing is hope and teamwork. Having someone following up with that patient. Tro has unbelievable data saying, why did people fail 99% of the time? Number one, stress, life stress, worry about diseases, all that kind of stuff. Number two, lack of support at home. That's it. Those are the big ones, right? So if you don't have support, people aren't helping you, and people aren't helping you along the way. And in my sense, it's building a community where you can help each other. Take us out of the picture and have a community saying, look, I hate this kind of food. What do I do? I'm Indian. I like this kind of food. Oh, here's how I do it. What Vic is doing, that's why I wanted to draw attention to that, what Italian goes keto, because so many people say, this is my culture and I'm just going to do it. What Kelly's doing, I mean, that's huge to say, let's get rid of the rice, let's change this. Ron Sinha is doing it with the Indian community and saying, hey, these are culturally relevant foods. Because if I tell you to eat pizza every day and you don't like pizza, that's dumb. If I tell you to eat fish every day and you hate it, it's not going to work. So it has to be palatable. It has to be something that we can make the patient understand. This is what we're going to do. Here's the process. To give you a diet plan is not going to fix the problem.
Hello, Patrick Tickman, Internal Medicine, Las Vegas. I've been practicing low-carb ketogenic diet for 5 years, and I've been prescribing it to my patients. At first, I was a little scared, and then I became very brave. Patients, coronary artery disease with bypass, peripheral artery disease, status post strokes, you go on a keto diet. But what happens? When they go back to their cardiologist tell them, oh no, you gotta be on a low-fat diet and tell your doctor he's killing you. So the patient comes back confused. I work with Optum Health, United Healthcare, big company. We're really concerned about our HEDI scores, 5-star ratings like that, so that we can get good Medicare reimbursements. They advise all diabetics, no matter what, has to be on statin, no matter what dose. So my question is to any one of you, how do you make the needle go forward when I'm swimming against the current of low-fat, high-carb river?
Yeah, I do know what you're talking. We all know. It is a little bit easier for me, I think, because many of my patients come to me because they know me from social media or because of my blog, so they are already sold to low carb. When it happens that somebody, was sent to me by a friend, but the person doesn't know about it, then I tell the person about low carb, and then his cardiologist, endocrinologist, whatever, tells him that this is crazy. And I take a lot of time explaining evidence, showing papers, so that the person knows I'm not talking on the top of my head, I have data to support it. But in the end, it comes to patient-physician trust. And sometimes you need to tell the patient, okay, you have two contradictory opinions here, you need to choose.
Yeah, I think results speak. People thought I was nuts 2 years ago. Like I thought Jason Fung was crazy when I heard his data initially, and now they're brilliant, right? You look at the clinical experience, what Rob Zivas is doing as a bariatric surgeon, reversing fatty liver disease, and all these other think tank people are trying to develop a drug to do something he could do in 3 days. It's unbelievable. So if I tell you I could do these things, and I think that's the key, is if my patient trusts me. The problem has always been in medicine, everyone knows diet doesn't work because we've been, I'm going to use Tro language in a second here. We've been giving really terrible advice on diet. Then we say it doesn't work. No one listens to us. No, they're listening. We're giving the wrong advice, right? So I think it's hard. But I'll give you a perfect example. I have a patient, 2 stents in his heart. I'm looking at his labs, and I say, look, you should go on a ketogenic diet. Cardiologist calls me right away. I'm friends with him. He goes, Brian, are you nuts? Well, you're putting yourself at major risk. I go, have you seen his insulin levels? 40. Should be less than 5. This guy's metabolic status, triglycerides through the door. You're giving him 5 medicines that treat a metabolic disease. So what happens? The guy's labs all normalized, LDL comes down, everything went like surprisingly perfect, lost a ton of weight, energy through the roof, everything's perfect, insulin drops down, all this stuff. What does the cardiologist note says? Oh, patient lost weight, so now his numbers got better. It has nothing to do with the insulin level. That's what I'm saying. It's hard because how many people, all those things I told you that we've debunked, that we have, not my opinion, is what the data shows. What Jason's been saying is true. All these things have been right. And so all you could do is show them the data and show them your results, because my patients who thought, my partners who thought I was nuts are now asking me, what's an insulin level? What's this? What's that? Because they're seeing, when you see results, it changes everything. Yeah. So it's weathering the storm is my advice. Yeah, I think we're over on time. So everyone, if you want to take a break or do it, we'll be up here if you want to have questions. We can stay and answer those questions. But everyone else can be. I think they're on a timing, right, Rod? I see Rod jumping up and down, waving his arms and everything.